It's Dr. Sabrina Siegel here with a special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy Show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. The next theme is on novel perspectives and treatment strategies for ADHD. Today, Dr. Andy Cutler interviews Dr. David Goodman on best practices for treating ADHD across the lifespan. Let's listen in to part 3 of our theme, Treating ADHD Across the Lifespan.
Hello and welcome once again to this podcast, the PsychopharmaStahlogy Show. Today is a very special podcast. We're going to be speaking with a really good friend of mine, Dr. David Goodman, about treating ADHD across the lifespan. And joining us, as always, is Dr. Stahl himself. So first, let me start off by saying hello, David. How are you?
Hey, Steve. How are you? Thanks for having me.
You got it. So, Steve, how are you doing?
Good, and I couldn't be more pleased to have somebody of Dr. Goodman's caliber to give us time to do this podcast. So thanks for being here, David.
Yeah.
You're welcome, Steve. Thanks.
I would agree. And Dr. Goodman is really one of the authorities on the topic, particularly of adults with ADHD, and he's been on our NEI faculty for quite a long time. And his talks are some of the best reviewed and highest rated.
I'm actually have a bone to pick with him because, you know, he beats by a couple of hundredths of a decimal point, both you and I, on our speaker ratings, and it's really making us look bad.
It's pretty frustrating. I would agree.
No, he's
well, I've learned my skills. I've learned my skills from you guys, but you know, those 100 points differences aren't statistically significant.
Oh, I like that.
So we're all
good point.
We're all about the same.
Our confidence intervals overlap. Well, anyway, confidence is certainly something I don't think any of us lack. Well, David, let's just dive in here. Let's just start out with some level setting basics here. How would you say ADHD presents differently in adults versus children and adolescents?
Well, you know, the children present with a lot of hyperactivity and restlessness. If you're a problem for other people as a child, that's when you get brought for an evaluation. So the males over females at a ratio of 3 to 1. Mm-hmm. As they get older, though, the issues are not behaviors that annoy others. It's the behaviors that annoy yourself. And so as an adult, if you can't execute consistently, whether it's at your job, whether it's at school or in your marriage or partnership with somebody, that's when people start saying, you know what, you're just not functioning at the level that we would otherwise expect. And there's this disparity between perceived intelligence and your level of execution. So it's underperformance academically and occupationally. The other issue with adults is, although there are psychiatric comorbidities for children, they tend to be at a lower level. And so a lot of the major psychiatric disorders develop in the adolescent age 15 to 22. That's when you get your first onset of depression, your first onset of bipolar disorder, etc. The anxiety disorders from childhood then carry on into adulthood. And so the psychiatric evaluation becomes so much more complicated with the various symptoms and being able to drop them in the appropriate diagnostic bucket. As the patient gets older, you know, your patients in your 40s, 50s, and 60s, the evaluation time is longer because the history is longer and you have that many more distracting, confounding factors. You have medical issues, you have sleep apnea, you have multiple medications that may be compromising people's cognition. So the evaluation process becomes increasingly difficult as the patient gets older. And we know that children with ADHD, 60 to 90%, will continue to have symptoms into adulthood to an impairing degree. So this is not a disorder that people grow out of, and you need to come off your medication when you graduate from your pediatrician.
So it sounds like it changes, it evolves, if you will, over time, and the problems become more cognitive, I guess, load and cognitive impairment. Of course, still problems with relationships, and then comorbidity, if I'm hearing you correctly.
Right. And so let me pick up on that, Steve, in regards to the cognitive. Everybody focuses on cognitive, distractibility, inattention. And so primary care physicians in particular may say, well, let's send them for neuropsychological testing, and then we'll be able to sort out whether they have ADHD or not. And that's an expensive process, not often covered by insurance companies, and can cost thousands of dollars. It doesn't really make the diagnosis of ADHD. The diagnosis is a clinical one by the trajectory of symptoms over time. And so sending somebody for neuropsychological testing may help confirm that they have attentional problems. But if the neuropsych testing comes back equivalent or ambivalent to normal, then you're still left with the clinical history that's more consistent with the diagnosis. So there's not a necessity to send people, or even a requisite to send people for neuropsychological testing, unless you want to sort out intelligence, learning disabilities, and executive function issues.
Yeah, it makes sense.
Can I ask here, one of the things is that the presentation, sort of like the change in adults when they have been diagnosed as a child is one thing, but there's growing skepticism we're hearing even from FDA and DEA and people like that there is a such thing as somebody whose diagnosis was missed and first gets diagnosed as an adult, as though that there's a lot of scrutiny going on about that, particularly if they get stimulants. So how can we basically assure that these people who maybe were missed and getting diagnosis as adults are really the real McCoy?
Well, that is a good question, Steve. And there's several factors here. The first is ADHD is a diagnosis whose symptoms are anchored in childhood, so that if you didn't have symptoms in childhood or early adolescence and you come to me at 25 and say, I'm having problems focusing at my work or in school or with my wife, I'm not sure what you have, but you probably don't have ADHD. So the inadequate comprehensive psychiatric diagnoses that are done by, in my opinion, online companies doing 30-minute evaluations really fall short in being able to make accurate diagnoses. And so we want to discourage people from being prescribed medications that they ought not be on. I know the FDA commissioner has said that the online services really did increase the demand, and that contributed to the shortage of stimulant medications. But in order to make an accurate diagnosis, it's childhood symptoms that carry forward through the course of somebody's life. The ADHD individual says, I can't remember never being this way. The non-ADHD person says, I wasn't having these cognitive problems 6 months ago. The other element, although it's not part of the DSM-5, is that it's highly genetic. So 80% of the contribution is genetic. We often go looking for a first-degree family member. If you have a first-degree family member with similar symptoms, it's very likely the person who's sitting in front of you has ADHD. So that's another factor to consider in increasing the accuracy, sensitivity, and specificity of your diagnosis.
Well, that's great. The other question I have is, do you ever use response to meds to help make the diagnosis? In other words, there may be a such thing as stimulant-responsive cognitive disorders that may or may not be ADHD. And so the question is whether you give an immediate release stimulant to an adult to take PRN who's suddenly, found cognitive problems at the age of 30 or whatever, as opposed to making them earn that stimulant by going through a process of either a non-stimulant or some psychotherapy or at least a controlled release stimulants. Do you ever use that approach to try to say, well, gee, this new adult presenting, might really have ADHD, or no, he doesn't or she doesn't because of the response to meds?
So the short answer is no, I don't. For this reason, that if I take you and me and Andy and we all take a stimulant, in about an hour, we'll all say our energy, our cognition, and our mood is better. That's not a function of a disorder. That's a function of changing dopamine and norepinephrine. And the outcome of that is the psychological experience of feeling more alert, feeling in a better mood, feeling more motivated. That doesn't mean you have a disorder. That just means I changed your brain chemistry from normal to supernormal. But the object for ADHD is we make a diagnosis that's a legitimate psychiatric disorder, We provide medication that corrects the presumed chemical imbalance. And the outcome of that is your inattention is better, your distractibility is less, your procrastination is better, your initiative is better, and your motivation. So we even the playing field from a disorder to normalizing your functioning versus performance enhancement, which is taking you from normal to supernormal. And so, no, coming back to your original question, and it's a critical question because, again, in primary care and people who don't have the time to make an accurate diagnosis or are not quite sure here, they say, well, let's give you the medication and see if you get better. 9 out of 10 of these people are going to come back and say, this is great. I want to stay on the medicine. Well, now you've got a prescriber who says, wow, yeah, I guess you have it. But that's a diagnosis that's been inaccurately made. And you end up with more people on these medications who ought not be prescribed. And they're not benign. You can have side effects. There are physiologic side effects of tachycardia and hypertension. There's psychiatric effects of mood lability, irritability, reactivity. So, no, we don't make a diagnosis. It would be like saying to the bipolar patient, I'm not sure if you have a bipolar disorder, but let's put you on lithium and see what happens. Mm-hmm. And the patient gets better. Well, should I presume you must have a lithium deficiency that has corrected your mood instability?
Yeah.
We don't think that way. I mean, you know this, Steve. You're a premier expert on neuropsychopharmacology. So, but the points are really critical for clinicians who have not been adequately trained on evaluating how to make accurate diagnoses and how to make use of these medications without using the medications to confirm your diagnosis.
Yeah, I mean, a lot of people use caffeine too, which is a stimulant. And so that doesn't mean you have a problem necessarily. It just means you're trying to pay better attention or something like that. I mean, the point you're making, David, about a comprehensive evaluation, I don't think can be overestimated. I think that's really the issue. And there is no test. I always love when people come in and say, I was tested for ADHD or I had them tested. There's no substitute for doing this clinical evaluation, understanding the disease in the ways you're talking about.
You and I, the three of us, are alleged experts. We know what it means to do a comprehensive psychiatric evaluation because we have been trained by our mentors how to do that.
Yeah.
I'm not sure that the concept of a psychiatric evaluation is really adequately trained in so many of the programs. And to take it a step further, very few psychiatric residency programs in the U.S. give more than 2 lectures on adult ADHD.
Well, you're lucky
so
if you
don't know how to do a comprehensive, if you don't know how to do a comprehensive evaluation and you don't know what adult ADHD looks like, you're never going to see it, and you're not going to have a confidence in the accuracy of your diagnosis. Yeah. Well, the other issue is, I mean, there's just so many issues here. The social phenomenon now of being able to go online and make a self-diagnosis, go into the prescriber and say, I think I have this, rattle off the symptoms without the interviewer being able to sort through the true phenomenologic psychological experience that they're having to make an accurate diagnosis. We end up with a generation of people who are just making their own diagnosis, trying to get themselves on the medication they think works, and suffering the unfortunate consequences of the cost of the medicine, but the side effects of medications that would be unanticipated because you don't have a comprehensive psychiatric evaluation.
Yeah, there's risk and stigma with the medicines, of course. You know, a lot of us were trained to do a psychiatric evaluation, but when I trained, there was no such thing as adult ADHD. It was completely a childhood disorder. And I think, as you've said, people are still not getting good training on ADHD in general, and certainly not on adults. So a lot of what I've learned has been on-the-job training, if you will, over the years. I want to ask you about, we talked a little bit about comorbidity. What are some of the common psychiatric and medical comorbidities? Because there's quite a few in adults, aren't there?
Right. So with the comorbidities, mood disorders are about 40% in ADHD individuals. Anxiety disorders are about 48%. So if you make an accurate diagnosis of ADHD in an adult, before you break your arm patting yourself on the back, go looking for other disorders. 70% of ADHD individuals have another psychiatric disorder. 50% of them have a second psychiatric disorder. So often you see these people with ADHD and bipolar disorder, ADHD major depression. You'll have complex cases where they have ADHD, bipolar disorder, OCD, and binge drinking disorders.
Yep.
And so knowing where to drop the symptoms into the accurate diagnosis becomes the clinical challenge. Now, the other bugaboo that people get into is that the mood disorder people are telling us that anxiety and depression cause cognitive difficulties. And so if you have somebody with depression who complains of cognitive difficulties,
Right.
but they have a history of ADHD, are those cognitive difficulties a function of the depression? Or are they a function of ADHD?
Right.
And how do you diagnostically prioritize which you treat first, second, and third in order to sort that out?
Right.
Because you have to come up with a pharmacologic algorithm that treats one disorder without making the others worse. This is really both complex and creative.
Yeah, absolutely. Well, we're talking about, as you mentioned, a dopamine dysregulation disorder. And of course, dopamine is not only attention and cognition, it's motivation reward, it's pleasure, it's hedonia, hedonic tone. And so there's a lot of self-medication. Pretty much every drug of abuse raises dopamine. That's why it's abused. So that always complicates it. Steve, what do you think?
Yeah, I think it's gone from categorical to dimensional is another way to look at this. Problems concentrating is a symptom of GAD. Problems concentrating is a symptom of major depressive disorder. Problems concentrating is a problem of ADHD. It's a problem of sleep disorders. It's a problem of narcolepsy, et cetera, et cetera.
Right.
It's probably the same circuit, and it probably responds the same. The problem is that the good data about safety versus efficacy occur in the syndrome of ADHD. Problems concentrating, as David's already said, can probably be fixed in many cases by a stimulant. And but the question is that really justified use of that? Because you can probably fix the problem in depression by treating the underlying disorder, and the cognition gets better as a consequence of the entire disorder getting better. You don't need a stimulant necessarily.
Yeah. David, I did want to talk about medical comorbidities because there are significant medical comorbidities, and there's even a risk of premature mortality. A lot of people don't understand this. ADHD is a lot more than just being a little spacey, isn't it?
It certainly is. So when you talk about medical comorbidities, are we talking about medical differentials or medical comorbidities? So you understand that a lot of medical issues, illnesses will cause cognitive difficulties.
Right.
And you have to sort out whether those cognitive difficulties are a function of the primary medical condition,
Right.
like diabetes or COPD, or whether the cognitive difficulties are an impairment of the ADHD.
Right.
So that's where you get into the differentials for cognitive changes, whether it's a medical and or whether it's ADHD or any of the other psychiatric disorders that Steve mentioned. In regards to the concurrent disorders, you have to think about those in consideration to what you prescribe for the ADHD. So in ADHD, you have the stimulants, methylphenidate, amphetamines. Then you have the non-stimulants, viloxazine, atomoxetine. You have the alpha-2 agonists, clonidine, guanfacine. So all of these will have effects on medical illnesses. And the most serious one that we consider are cardiovascular. Yeah. As your patients get older, and I particularly am interested and have written about ADHD over the age of 50, we now have cardiac issues that are significant. So you have to decide whether the benefit of prescribing ADHD medications merits it over the risk of the cardiovascular. And so there's just too many medical illnesses to go through specifically. It is interesting, and we can talk about perhaps later the effects of hormonal changes in women, either through pregnancy or the menstrual cycle or perimenopause, and the effects of hormones on cognitive ability and how that affects different networks in the brain.
Yeah, I definitely want to get into ADHD in women in a minute and elderly, but what I'm really referring to is the comorbidities that have been seen with adults with ADHD. For instance, one of the highest genetic linkages, and I just heard this at the most recent APSAR meeting, is actually elevated BMI. So adults with ADHD are heavier, more obesity, and along with that comes more diabetes and more cardiovascular disease. I mean, that is just part of the package here, it seems like, for whatever reason. And, it could be, again, dysregulation of the motivation reward system leads to overeating and things like that, binge eating, as we talked about. And then, the classic Sun article that shows, with ADHD, just ADHD, you have a higher risk of premature mortality just by itself. But as you layer on comorbidities, my goodness, it goes up logarithmically. And that includes a higher rate of suicide with untreated ADHD. And of course, the medical comorbidities, accidents, things like that. So my point was simply, this is a lot more than just a little spacey. And it's really, to me, the urgency to recognize and treat this condition.
Well, and you're absolutely right. So it's great that you highlight that, because this is a disorder that has a tremendous impact on people's lives in a variety of factors. It's interesting. There was an article that came out just last month showing that the odds ratio for cardiovascular events is independently associated with ADHD at an odds ratio of 1.79.
Oh my goodness.
It's very similar to the odds ratio for, actually, it's higher than the odds ratio for obesity and equal to the odds ratio for depression. So ADHD itself predisposes people to higher morbidity, medical morbidity and mortality. And then you add on all of the other factors of BMI, obesity, cardiovascular disease, smoking, alcohol. And as you said, the mortality is 7 years shorter than the average lifespan.
Incredible. Now, you're talking about that cardiovascular. That was independent of stimulant medication, I'm assuming.
It was independent of stimulant medication and also considered SSRIs or other psychiatric medications.
That's incredible. So, of course, we need to consider these things when we're choosing our treatments. And you talked about the elderly. My understanding from you, David, is that if you aggressively treat hypertension and monitor blood pressure, you can use stimulants in older folks. Is that right?
You can. So a lot of people don't know about ADHD in older adults. As I said earlier, ADHD doesn't go away when you get discharged by your pediatrician, and it doesn't go away when you get your ARP card or your Medicare card. So this is something that people live with their entire life. Most of the people over the age of 50 have never been diagnosed. And so if you make a diagnosis of ADHD in adults predicated on the fact that it was diagnosed as a child, you're going to miss 100% of the ADHD individuals over the age of 50. It's also easy to dismiss cognitive complaints in older patients because you say, well, you know, you're in your late 50s, you're in your 60s, you're pushing 70. It's part of normal aging, without having done at least a preliminary screen for ADHD in those patients. And what's remarkable is that if you discount this or you call it early MCI, mild cognitive impairment, you really miss the opportunity to treat ADHD and improve the quality of this person's life, not only for the next week, but for the next several years. Unfortunately, ADHD in the memory clinics is only now just starting to be recognized. So a study several years ago showed that only 20% of the memory clinics were even assessing for ADHD.
That's remarkable.
And then you go, okay, well, you know, why should I bother treating these people? Well, you only have to have the experience of treating a 65-year-old who has never been treated. And you treat them and they come back and they say, is this how normal people live? And I say, yes, this is what normal people experience. And they say, well, this is remarkable. And then there's a whole psychotherapy that goes through because people grieve the lost opportunities.
Exactly.
They grieve the fact that they were told they were lazy and stupid. Gee, I'll never forget. I had a Hispanic woman come into me. She was 45 years old. I told her she had ADHD and she started crying. And I said, well, I'm sorry. Did I say something to upset you? She said, no, I'm actually happy because my family told me I was mentally retarded my entire life.
Wow.
And now all of a sudden she realized, you know what? I'm not mentally retarded. I had ADHD and now I can function at this level. So, for those of us who treat ADHD, it's remarkable. There are two psychiatric conditions that you can treat in an hour or two: panic disorder with a benzo or ADHD with a stimulant medication.
Yeah, it is very rewarding. I agree. And I really love that you brought this up, David, because for our listening audience, I think an integral part of treating adults with ADHD, especially if they were never previously diagnosed, is this grieving process and kind of having to reassess your life and say, what was the ADHD? What was me? You know, what is my identity? The self-esteem issues, the recognition that, oh my God, you mean I had this condition that was treatable my whole life and my life could have been different, as you said. So I'm glad we brought that up. Treating ADHD is more than just throwing pills at people. It really is a complex process, isn't it?
Yes.
Okay, how about, you mentioned there is a newer non-stimulant. We now have 2 non-stimulants FDA approved to treat adults, and I'm referring to viloxazine extended release. Also, our friend Rick Weissler a few years back published a meta-analysis of bupropion for ADHD. So what is the role of non-stimulants in an older adult with ADHD?
So it's the same as using stimulant medications.
Mm-hmm.
You want to assess where you want to start in your pharmacologic algorithm. If you start with non-stimulants, you want to think about the rate of titration. You want to think about drug-drug interactions because atomoxetine is a 2D6 substrate. So anything that interferes with that will alter metabolism. Viloxazine has a strong inhibitory effects on 1A2. So you want to think about drug interactions there.
Yeah.
And that becomes complicated then in the elderly. I reluctantly say elderly. I'm only saying it because you guys say it. I say older adults because I don't consider myself elderly, even though I probably would be to a 25-year-old.
Yeah.
So you think about the medical illness. You think about the medications that they're on for drug-drug interactions, and then you think about how you'll titrate upward. Whether you start with a non-stimulant or a stimulant is just going to be based on the clinical profile of the patient and your sense of comfort with the medications. Both the atomoxetine and viloxazine studies maxed age out at 65. So unfortunately, we don't have a lot of data. In fact, we have very little data on the use of both stimulants and non-stimulants in over the age of 65.
Yeah.
There's some body of work over the age of 65, and I'm first author on the first literature review of ADHD over the age of 50. But the real question is more of the clinician's concern about safety. There's no particular reason to get EKGs, although many of these patients are going to have cardiac issues. They'll probably have a cardiologist. And so if I do prescribe medications, I'll talk to the cardiologist if I have concerns. A cardiac disease in and of itself is not really an absolute contraindication. There was a recent review on stimulant use in older adults just published in February of 23. So you just have to be careful, monitor blood pressure and pulse, advise the patient, go slow on the dosing, and see what their response is. How do you measure response? I typically use an adult ADHD self-report scale. It's the 18 items out of the DSM-5. Patients can rate this themselves. It's based on a frequency of 0 to 4 scale, and it takes 60 seconds. And it's really easy for the patient to fill this out. It's time efficient for people who have little time for patients.
Yeah, absolutely. I really like that you brought up, as people get older, and this has happened with me, and first of all, I like the idea of older adults versus elderly. Thank you for that. We accumulate medications, and I think that part of our comprehensive evaluation is to figure out all of the medications someone's taking, even if prescribed by others, and really take into account these drug-drug interactions. It's something I worry about. Also, people take things over the counter. Particularly, there's many supplements that purport to improve cognition, and a lot of supplements have what I call caffeine in disguise, things like guarana and other alkaloids, this kind of thing. So we need to understand all of that.
That's an important point. I want to highlight that there are a lot of supplements on the market purporting to support cognition, in quotes. There is no proof that they do that. In fact, several of them have been disproven. And you can try that. If you decide to do that, then do it for 2 months. Decide what your target symptoms are. And at the end of 2 months of doing that, decide whether it really has been helpful or not. If it hasn't been helpful, let's move on. There are 2 obstacles to patients accessing care. One is the belief that they can find supplements that are helpful. So it delays seeing a competent clinician for an evaluation and prescription. And also, the other issue is both ethnic and religious. So there are ethnic communities that don't see mental health as a medical issue, but more as a personal issue. So African Americans, Hispanic, Asian Americans, Latin Americans, they're culturally disengaged from the mental health system. And that's problematic. That's been clearly documented.
Yeah.
So those of you who are working with ethnicities need to be sensitive to that. The other is the religious orientation. And that is in certain religions, in both Muslim and Catholicism, it's God has put these challenges in front of you in order to overcome them and test you. And it's seen in a religious format, not a medical format. And so clinicians have to be sensitive to these issues when they talk to the patients who might be reluctant about engaging in mental health treatment.
Yeah, I would add Seventh-day Adventism to the religions that are skeptical of mental health. I appreciate that. Let's shift gears here. Let's talk about women versus men. Women are the group that is fastest growing as far as being recognized and diagnosed with ADHD right now. Women over the age of 19 is actually the fastest growing group. Let me ask you a couple quick questions and set you up before we get into this. And the first one is, you alluded to this earlier, that in children, there's a 3-to-1 ratio, boys to girls being recognized with ADHD, but it approaches 1-to-1 in adulthood. Do you think ADHD is really more common in boys, or do you think it's a recognition issue? What do you think is going on?
I think it's a recognition issue. I think it's the symptoms that present that people observe. It's the difference between the observer making a diagnosis, if you will, of disruptive behavior that's problematic versus older in life where you realize you're not functioning at the level that your peers are functioning. And so the referral for children is often by a parent or a teacher. The referral for an adult is often themselves. So that's why the girls tend to increase in the diagnosis as the environmental demands increase and their ability to compensate is compromised. Now, the risk factors for not getting diagnosed are being bright, having a structured environment / a partner, or being female.
Interesting.
And so now I'll add a comment that's going to be controversial. And the controversy here is the delay in making a diagnosis in women a sexist bias? In other words, the ascription of psychological symptoms for women is different than the ascription of psychological symptoms for men. And it has been documented that women have a delay in getting certain medical and psychiatric diagnoses over their male counterparts.
Well, I've had a patient of mine who was diagnosed in college, a young lady, who said that her diagnosis during childhood, because she wasn't climbing on desks, was that she was blonde. And she was very, very upset about that, and felt that she was just a space cadet, just a crazy girl, just to be dismissed. And that is an index of suspicion that should arouse the thought of ADHD in a young woman, a girl, as opposed to they don't crawl on desks and push guys around, and they're not hyperactive as much. I mean, not necessarily.
And that's a great point. I had an airline stewardess who cried again when I make the diagnosis and treated her, and she said, "I'm crying because my whole life people thought that I was blonde and stupid."
Yeah, exactly.
And she was not.
Yeah, boys tend to, and males tend to act out and externalize. Women tend to internalize. And there is, of course, a lot of social stigma and social norms of behavior and this kind of thing. So I appreciate you saying that. It is potentially controversial, but I think it's appropriate to say. I'm wondering, David, too, how much of this relatively recent rise in the recognition in women had to do with COVID? Frankly, women, as we know, wear many hats. They have many things going on. And with COVID, now all of a sudden, kids are home from school. They're not going to the office. Routines are disrupted. There's just more on their plate. Do you think that played a role?
I think COVID did play a role in increasing the diagnosis of ADHD. I remember I had a woman who said her daughter must have ADHD, but the father absolutely refused. The mother and father were separated. And during COVID, the daughter had to spend much more time with dad.
Yeah. And
at the end of the week, dad called mom and said, would you get this kid evaluated for ADHD?
Exactly.
So for years, he had put off getting the diagnosis. I do think that the absence of structure for many ADHD individuals who no longer had to go to work and be in a work environment, they now had to be at home and structure themselves, really was problematic.
Yes.
However, I've also had people who say, thank God I don't have to be in the office.
Right.
I'm not distracted.
Right.
I can sit in a room with no windows, no noise, and be highly productive.
Right.
So I think it was very much dependent on what the demands were, what the environment was, what your social support was. Did you have a spouse? Did you have a partner? But definitely, and we know from prescription rates, the prescription rates, which typically had been about 4 or 5% annual growth, jumped up over 10% from 21 to 22. And that's documented by the FDA.
Yeah, absolutely. If I could go back to your comment earlier about the father spending more time, our friend Greg Mattingly that Steve and I did a podcast with just recently, he likes to say with kids, the calls tend to go to the mom from school when there's a problem. And he'll tell them, just start having the calls go to dad and we'll see how quickly he agrees with the diagnosis and says we need to get help. Okay, furthering our discussion here of women. First of all, David, I have to commend you. You gave a stellar talk at the NEI Congress a couple years back on what's known about ADHD in women and reviewed the literature. And so you're a perfect person to talk to about this. We talked about how ADHD can present differently, certainly, but what about the hormonal changes? You mentioned this earlier. How does that impact both the presentation and, of course, the treatment?
So for those listeners who are really sparked by this, I would strongly encourage you to take advantage of your NEI membership and go back and listen to my lecture about a year ago that was delivered at Synapse. It really covers it from soup to nuts. Let me just focus on one that is particularly pertinent, and that is the women in perimenopause. So in perimenopause, where the estrogen levels are dropping, women will contemporaneously complain of cognitive changes. And for a long time, it was dismissed. Again, I think it was a sexist bias, but it was dismissed. The literature was equivocal at best. But it's now become clear that estrogen is pro-cognitive, that there are estrogen and sex hormone receptors in the prefrontal cortex through which many of the networks travel through. And so in perimenopause, as the estrogen decreases, women complain of this. Now, if you have somebody who has ADHD who starts complaining about a decline in cognition, is it because their ADHD is getting worse? Or is it because the cognitive effects are being worsened by a decline in estrogen? Depending on what you decide will determine what you do pharmacologically. Do I increase my ADHD medication? Or do I send the woman to an OBGYN to have an HRT trial for 3 months to see whether that corrects? Now, whether they're on HRT has other factors to be considered. If you're a post-breast cancer patient, for example, then there are considerations as to what that is. But it's clear that the ADHD woman going into perimenopause will complain cognitive ability is worse. Now, if you've been diagnosed with ADHD, what I've just laid out is pretty clinically clear. If you've never been diagnosed with ADHD and now you come in complaining about cognitive decline over the last few years and you don't assess this woman for ADHD, you may go in a different direction and miss the opportunity to treat the ADHD rather than simply put the woman on HRT. So that's a very important clinical distinction. And having said all of that with great confidence, is there a lot of research? No. My opinion here has been cobbled together from whatever the prevailing research exists and having treated patients for the last 37 years. But it is interesting, and I think the next clinical frontier of ADHD is in older adults, both for women, for their hormonal issues, as well as for men. And if you want, at some point, we have the opportunity to talk about older adults going from ADHD to MCI to early dementia,
Right.
and how you sort out the differential diagnosis. And then how do you decide what the concurrent comorbid aspects of that, and how do you construct your pharmacologic algorithm to take into consideration all of those presenting disorders?
Well, I just was wondering as you're talking whether you feel that you can optimize the treatment of ADHD in a postmenopausal woman in the absence of HRT. Does dopamine work as well when hormones are low? And then a kind of corollary to that is that the fluctuating hormones occur in perimenopause. Do you find that ADHD fluctuates as the hormones do, and that the stimulants help that?
So the cognitive ability definitely declines with declining estrogen in the ADHD individual. And then the question is, do you go to HRT or do you go to stimulant? I will often go to HRT first for 3 months to see whether that works. If that's substantially helpful, I mitigate against increasing stimulant medication. If they go to HRT or they're told that they cannot be on HRT at all, then I'll go to increasing the stimulant medication gingerly while following cardiovascular vital signs. And that does improve it. This ties into, we're talking about declining estrogen physiologically, but we also have declining estrogen by prescription, and that is in women with breast cancer to whom we prescribe estrogen-reducing compounds. What happens cognitively? It appears that if you're using tamoxifen, anything that interferes with the estrogen receptor or the estrogen synthesis also compromises cognition. So there is a body of literature that's looking at that. Now, if you have somebody with ADHD breast cancer who goes on tamoxifen, they're going to complain their cognitive ability is worse. Now, what do you do there? They can't come off the tamoxifen. In those patients, I've actually increased the stimulant, and it's been helpful. Is there any literature published on what I just said? Not a single paper. But these are the clinical issues, Steve and Andy, that our patients want answered.
Well, how much do you think chemo brain is ADHD exacerbation?
So you have to decide whether ADHD predated the chemo brain. It's a trajectory, not a cross-sectional symptom checklist. So you can have people who don't have ADHD and have chemo brain, or you can have people with ADHD and chemo brain that worsens their cognitive ability. And again, just like in the perimenopausal woman, do you go to HRT? Do you stop your tamoxifen, or do you increase your stimulant medication? There's not any literature to give us clinical guidance, and so you have to construct your own pharmacologic algorithm and decide what the target symptoms are over the course of time, which speaks to why it is so important for patients to have continuity of care with a single provider who knows how to track this. If you're seeing a different clinician every time you go to a clinic, it is very hard for them to come up with a plan to treat this.
What about, David, you're sort of alluding to this notion that people with ADHD have higher risk for dementia, or that it somehow leads to dementia. I realize we talked about how it can be hard to tease that out, but do you believe there's really an association there, or what do you think is going on?
That's interesting because we call ADHD a neurodevelopmental disorder, and there's a body of literature that's questioning whether it's not a neurodegenerative disorder. So there's some research that looks at ADHD associated with Alzheimer's, with Parkinson's disease, and with Lewy body. The one piece of evidence that's probably the strongest is the ADHD association with Lewy bodies at a 5-fold higher risk.
Wow.
But I think that's only 1 or 2 studies, so let's not take it to the bank. But we should be mindful in following the ADHD patients when they get older, whether they're at risk for. Now, when I said earlier that I have a patient with I've had several patients with ADHD who developed MCI and then went on to early dementia, I'm not making association between the ADHD and the dementia. I am highlighting the clinical challenge of deciding what cognitive symptoms constitute the ADHD, what clinical symptoms constitute the MCI, and what symptoms constitute the dementia. There are neuropsychological differences in the cognitive abilities of each of these people.
Right.
For example, an ADHD individual is not likely to have problems misspelling words unless they have a learning disability,
right,
or difficulty finding words when they're speaking.
Mm-hmm.
The MCI patient
Right.
is probably going to have difficulty finding words and misspelling. The Alzheimer's patient is now going to have difficulty keeping track of their thought in mid-paragraph or mid-sentence. So these are the subtle cognitive differences. And then for those patients, do you continue them on their stimulant medication?
Right.
Is that really helpful? And or do you go to a donepezil, for example, and can you use the two together?
Right.
You know, I'm so passionate about this area because the absence of literature is so stark that we don't have clinical answers and guidance on this.
Yeah, I wonder also if some of the association might not be with something we mentioned earlier, which is more obesity, more hypertension, more diabetes, which we know are independent risk factors for dementias. So it is very complex. Okay, I know we're running a little bit short on time here, but let's just sort of finish the conversation about women, since it is so important. Are there other challenges in treating women with ADHD? I mean, there are women who have polycystic ovary and endometriosis, menopause we talked about. What would you say about those?
Well, it's polycystic ovary syndrome is interesting. Also, Ehlers-Danlos syndrome, that's common and highly genetic in females, is also interesting. Both of those present with cognitive complaints. Let's just talk about PCOS, which is a hyperandrogen syndrome with obesity and either amenorrhea or irregular menses. And they present with cognitive difficulties. They're also highly associated with depression and anxiety disorders. It's interesting, if you look at the literature 20 years ago, ADHD wasn't even part of the research rubric. So there's no data on the association with PCOS and ADHD, but there is an association with PCOS and cognitive difficulties. I have patients with PCOS and ADHD. Again, I say the same thing over and over. ADHD is something that starts in childhood or early adolescence. PCOS certainly starts at the pubertal time. And then moving forward, you track the cognitive symptoms and the impairments. But I have patients with PCOS who are on oral contraception and spironolactone, which is an anti-androgen. So that's the common combination. If they still have cognitive difficulties from their ADHD, then I add the stimulant or I add an ADHD medication in order to treat them. And so again, it comes down to which diagnostic category do you ascribe the cognitive changes?
Right.
Is it a function of the PCOS? Is it ADHD? Is it their anxiety and depression? And that's why doing cross-sectional diagnosis of cognitive symptoms is not going to give you an accurate read. It's really the trajectory of symptoms over the course of time and what is qualitatively changing.
Well, and of course, it could be all of the above. It's not necessarily neither or here, right?
Exactly.
What about endometriosis? Is there any association or any issues there we need to be aware of?
There isn't an association with ADHD and endometriosis, primarily because there's not a lot of research on them. There's some research on cognitive changes. Endometriosis occurs at a prevalence rate of about 10% for women.
Wow.
So it's not uncommon, but it's more associated with anxiety and depression as a function of severe painful events during their during their periods.
Right.
But not so much ADHD. Interesting, bipolar disorder has a 6-fold risk associated with endometriosis.
I had no idea.
Who knows why?
Yeah, that's fascinating.
Right. So I don't change my pharmacologic treatment. And I haven't talked about psychotherapy, but clearly if you've been listening to this podcast, you know that all of us truly believe in the essential aspects of approaching our patients with psychotherapeutic skills.
Certainly that, and also lifestyle modifications. I'm a fan of coaching, if you will. I'm certainly a fan of digital devices and apps and various other ways to help people with organization and keeping track of things and the like. There's one thing I definitely want to talk about before we go, and that is I mentioned that for me in my training, there was no such thing as adult ADHD. Well, finally, over the years, people acknowledged that it can persist into adulthood, and the classic statistic we were given was 50 to 60% of the time, but that was based on point prevalence, of course. And about a year ago, as you know, a year and a half ago, our friend Maggie Sibley and colleagues published an article that is, to me, very important, that showed, no, if you follow adults over years, what you find is that 90% of the time, approximately, it persists. However, it can wax and wane depending on environment and stressors. I think that's really important for our audience, don't you, to realize?
That the symptoms may fluctuate, the impairments fluctuate. The impairments are really a function of environmental demand,
right,
and innate compensatory skills, scaffold support systems, and intelligence.
Yeah.
And so the impairments fluctuate depending on the demands of the environment. It's also why when patients come to see me, I say, well, why now are you coming to see me? Because you've had this since you were a child or early adolescence. Why now has this become an issue? Well, I'm anxious because I'm going to lose my job. I'm depressed because my partner is going to leave me. I've run up a lot of debt from impulsive spending and I can no longer handle the payments. So find out what's causing them to come in now. And that becomes the leverage for both psychotherapy and pharmacologic intervention.
Yeah, I love that. For all psychiatric disorders, that's a big question in my mind. Why now? Because usually people have had symptoms for a while. And if you're not addressing the why now, you're really not addressing probably what's most important to that patient. But I think the idea, too, of this persistence, this is, as you mentioned earlier, and I agree with you 1,000%, this is a highly genetic disorder that you can demonstrate, I like to say, neurologic wiring issues. There's not many, I don't know of any other medical illness like that goes away, that simply goes away.
I agree.
Okay.
And I hope those of you who took the time to listen to this podcast, I'm grateful to be invited to such an esteemed venue. I hope that those of you who are interested take this seriously and say, let me identify a couple of patients who clearly had problems their whole life and treat them. And once you have the rewarding experience of treating a patient who comes back to you with tears in their eyes and says, is this how normal people function? You'll realize that this is more than just a benign complaint that people have.
Yeah, also, just because somebody wasn't diagnosed earlier doesn't mean they don't have ADHD. As we've said, there are many reasons people don't get diagnosed earlier. You mentioned something a professor of mine once said to me, IQ points can compensate for a lot. and the other things we all talked about, but also the stigma and the fact that people didn't believe in ADHD, or they thought it was just, you're just being, a boy, or difficult, or you just need to, you're lazy, you're crazy, you're stupid, all of the things we talked about. But I think you're right that taking a longitudinal history is critically important, because you may find out the person has had symptoms. Maybe they were able to compensate, or maybe they were, what I look for is underachievement. Someone who's very bright and should be in a professional job or should have done well in school, who just got by. And it can get missed if somebody's, doing average, but there's someone with the potential for above average. So I think these are some of the things to consider as well.
Before we leave, Andy, I do want to impart that while we're advocates for an accurate diagnosis and effective treatment, that clinicians are also mindful that they don't want to be gamed by patients coming in, giving them the story in order to get a diagnosis and therefore get much needed stimulant medications. So a word to clinicians concerned about that, to accept this as a real condition that is heartfelt and impairing, but also being mindful to take the history from patients and get a good clinical interview in order to verify. If you're questioning, then get an outside observer to give you some collateral information about the historical functioning of this person, but not simply to dismiss people as saying, well, they're just stimulant drug seeking.
Right.
This has become an issue in the college campuses.
Right.
Because my Hopkins fellow, who's doing research on 200 universities around the country, has come to the conclusion there's no organized national body that oversees the practices on college mental health campuses. And so everybody is just trying to make this up and do the best they can.
Mm-hmm.
And some clinicians dismiss these college students while others may be overly concerned and may be overly prescribing. So again, just to say this is a real disorder,
right,
to be mindful to get an accurate history and diagnosis.
Right. And I always look for not just what are the symptoms, but how do they impact the person's life? And that's where I can distinguish the game players who've learned what to say, on the internet or something, or, nowadays TikTok videos are incredible. But, ask about how does it impact you? In what ways? And the person who has every symptom and it's totally impacting my life, well, I'm a little more skeptical of that.
Yeah.
All right. I want to just end, if we could, on the elephant in the living room, which is the shortage of stimulant medications, particularly the amphetamines and particularly the immediate release amphetamines. We don't have time to get into why this is. It's multifactorial, of course. But unfortunately, a lot of people are looking at stimulants as the new opioid crisis. And so patients are suffering. There are patients who legitimately, as we've said, need these medications who can't get them. What can we say to help our audience here to deal with this situation?
Well, Andy, we could talk about the sequence of factors that created the tsunami of the shortage, which I think would be a long additional podcast.
Yes.
Or we can offer suggestions to patients who are having these difficulties.
Mm-hmm.
My experience then over the last several years, and I've been very involved in commenting and keeping track of this, is the shortage is very much geographic. Mm-hmm. And it's also by distributors of the stimulant medications. So there are three major distributors of the medications, and they distribute to the retail pharmacies. So one pharmacy may be able to get it, and another pharmacy may not be able to get it. So you sometimes have to pharmacy shop. Difficulty with that is the pharmacies won't tell you what they have in the inventory. It's complicated by the fact that we're now either by choice or by regulation submitting these C2 prescriptions electronically. So you send it to one and the pharmacy doesn't have it, and you have to send it to another. And so that becomes an administrative burden for the clinician. For the patient, sometimes the workaround is if they don't have an Adderall XR20, they have Adderall XR10s. You can change the milligram pill size.
Mm-hmm.
Sometimes they simply just don't have it, and you have to change the medication. If you're going to change the medication, it's probably best to stay in the same compound. So if the patient is on an amphetamine, go to another long-acting amphetamine. If they're on a methylphenidate, stay with another long-acting methylphenidate.
Mm-hmm.
The non-stimulants seem not to have a shortage issue,
right?
But the shortage has gone from Adderall immediate release to Adderall XR, and then out to all of the methylphenidate group as well.
Yeah.
My experience clinically is that it is lessening, at least where I operate in Baltimore. Mm-hmm. But Florida still represents a problem. I know,
does.
Andy, you're down in Florida, so
I definitely know this.
I don't know if they have Adderall at all.
Very, very hard to get, and they ration it out.
Yeah. There are so many regulatory issues here. The DEA controls the annual amount of compound that's allowed for the manufacturers. The manufacturers don't necessarily report the amounts that they're sending out to the distributors.
Mm-hmm.
The distributors aren't keeping track of who they're sending out to the retails.
Mm-hmm.
The retail organizations have quotas per month. So if they pass their quota, they can't get any more drug.
Mm-hmm.
I mean, there's a lot of obstacles in order for the medicine to go from the manufacturer to the patient's hand.
Yeah, it certainly is. And, we're entering the summertime here. This is an opportunity perhaps to switch medication, try something new. We mentioned Viloxazine XR is a viable option, and the others. Well, believe it or not, David, as always, talking with you is fun and fascinating, but the time here has come to a close. And I strongly agree with you, David. For people who want to know more, please go to our website at NEIglobal.com, and you can join membership, and you can get the encore broadcasts from some of the lectures. We've had some terrific talks on ADHD, which is always one of our audiences and our members' biggest topics they want to hear more about. So we're going to wrap up here, but Steve, I wanted to give you an opportunity. Any final thoughts or pieces of wisdom for our audience?
I have no final thoughts and absolutely no wisdom after being schooled here by Dr. Goodman. So thanks for your time, Dave.
Yes. Really.
Oh, you're welcome, Steve. Thanks.
Really. Thanks, everybody. So please tune in for more episodes of the PsychopharmaStahlogy podcast. And as we mentioned, please go to our website for more of our educational offerings, and that's at NEIglobal.com. Thank you.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.